Dr. Siren. It's Sonia.
And Melissa. And Carly.
And Valerie. It's a little dark, so it might be a little hard to see us. So our topic is on cleft lip and cleft palate, specifically which treatment approach is more effective, prosthetic, or surgical. So cleft lip and cleft palate is one of the most common oral facial disorders, especially in the Philippines. It is found in 1 in 500 children in that country. We really wanted to focus on this population because it is so prevalent. In order to do so, we wanted to compare two treatment approaches, prosthetic versus surgical, before and after usage. These treatment approaches will focus on the ability to lower hypernasality in children with cleft lip and cleft palate. We really wanted to focus on hypernasality specifically because it is pertinent. It is most pertinent because it is a frequent resonance disorder in this population. And in order to decipher which is the most effective, we will be based on the treatment's ability to lower hypernasality, which we will later determine in our study. This is just a brief summary of the different terminology that we use and just basically what I went over. And more specifically, our research question is, which intervention, surgery, or prosthetic is more effective for correcting hypernasality for vowels in children with cleft lip and cleft palate?
Okay, so in our research, we looked at the surgical approach and the prosthetic approach. We found that the prosthetic is more temporary, especially with adults, but it all depends on the individual. If they're already past the developmental stage where their mouth is growing, especially the upper alveolar ridge, then they would go with the temporary approach. We found that surgery is a more permanent approach to fixing the cleft palate, typically done with children, and it's done over the course of a few years just because they are growing.
Okay, so for our study, our participants will be 30 children ages 3 to 5, and there'll be 15 boys that will be given the surgical treatment group, and then 15 boys and girls who will be in the prosthetic treatment group. And the children must meet the following criteria. They must meet the age and the language requirement. They must speak English fluently, and they must have a bullopharyngeal insufficiency level of mild to severe. A couple of variables that will affect the data and analysis are whether the patient receives surgery or a prosthetic, post-treatment and surgery time, and how long they've had the cleft palate and also their native language. These children must meet the criterion. The children that meet the criterion will be randomly selected from a cleft lip and cleft palate clinic in the Philippines.
So, our method will be that we will start before they have their surgery or prosthetic put in, and we will evaluate them based on 240 words that we will give to them at every treatment or at every therapy session. So we would use 20 words at the beginning of each session and then work through them throughout the session. So they're going to have 12 therapy sessions prior to treatment and then another 12 after treatment. And during both pre and post, we're going to video them throughout the whole therapy sessions and be able to see how they progress before and after, and especially to compare their hypernasality and to make sure that their prosthetic or surgery was efficient. So to lay out how a therapy session would go, we would present the 20 verb cards containing a picture of a child performing an activity. So, for example, if Sonia was the client, I would say to Sonia, what is the child doing in this picture?
Jumping.
And so since she gave a clear answer and it was articulated well, that would be correct. But we would expect that in the treatment or in the therapy sessions before treatment, they would have a very, very low score and wouldn't be able to articulate correctly. But after treatment, we would expect much higher scores at the beginning, and we would be able to prove this by the video evidence that we collected.
And also, it's important within this, throughout the methodology, that the SLP tries not to intervene just so that the results are concrete before and after in order to see which really does have the best effect. And because if the SLP does intervene throughout this portion, that might affect the results.
So in each therapy session, we want to avoid peer influence and remain the individual's attention. So the therapy session will occur 30 minutes for a period of 4 weeks, post-surgery and after. Then we'll have follow-up consisting of 3 sessions per week for 30 minutes after the child used prosthetics or had surgery for 2 years. We will be using the Boral-Mizini scale, which is a scale that judges the nasality of the vowels. So it's from type 0 to 3. Type 0 means there's no phonation. Type 1, it's excellent phonation, no nasal air emission. Type 1-2 is good phonation, intermittent nasal air emission, and good intelligibility. Type 2 is phonation with continued nasal emission. And type 2B is phonation with continued nasal emission, good intelligibility, and social discomfort. Type 2M is phonation with continued nasal emission and poor intelligibility. And type 2-3 is phonation with continued nasal emission with compensatory articulation and poor intelligibility. And lastly, type 3 is continued compensation articulation, no intelligibility. So based on the scale, we will be able to determine how effective each intervention was and judge based on the hypernasality of each vowel.
So in conclusion, based on our article findings, we believe that surgical intervention will be most effective for the children we want to treat at the Philippines clinic because surgeries work better with children as opposed to adults, and that is our target audience. Exactly.
Right. That's it.
Thank you.
Thank you.